Yeah, I'm Saif Mohammed, and I'm joining from Kerala, India, from Calicut, which is a northern city in Kerala. And I'm joining from Institute of Palliative Medicine, which is one of the WHO collaborating centers, and also the first palliative care institutions in the whole of Kerala, which was founded by the first palliative care society in Kerala, called as the Pain and Palliative Care Society in 1993. And I started off as a volunteer when I was in college. Then after that, I served as the state project manager for the government palliative care program, for which our institute, IPM, was the nodal center. Then now I'm working as the academic consultant at the Institute of Palliative Medicine, basically developing programs around community palliative care, bereavement, and things like that. But as doctors and nurses, they are busy and they work within an institution. It can be an hospice or a hospital. So what they do is that they usually look at the medical component, their physical issues. But unless and until the other issues are not attended, I think you're not getting to the total care of the patient. But for that to happen, you will not be able to do it alone. And in Kerala, one thing that we have realized is that we were able to recognize palliative care more as a social issue with a medical component rather than a medical issue with a social component. And when you look at the problems faced by the patient, there are clinical issues, there are physical issues that you have to address to. But if you look at the wide range of other issues, it's not something a doctor and nurse can prescribe medicine for. It's something that the community has to come together, learn the skills, and support each other to address those issues. And when the clinical team and the community come together, what I've seen is that it can result in a lot of impact on the well-being of the patient and the family. One thing that I've noticed is that when the doctor or a nurse goes to the home or to the house of the patient, you'll get the real picture. So you may be prescribing medicine, you may be prescribing a lot of things there, but unless you understand the real picture of the patient and the family, sometimes it's futile. That you don't know whether the patient is going to have the medicine. You don't know whether the patient will be in our settings. That if the patient will be able to afford the medicine, and what are the other issues in that house, who are all there to support them. So all these things you'll not be able to see unless you go there and see it for yourself. And once you're there in the community, you're respected more, because you're someone who is coming to the house, and the whole family knows that you're an integral part of the care. The community also knows that this person is going there and doing whatever needs to be done. So that not only boosts the morale of the patient and the family, but also that imparts a lot of respect for the clinicians themselves. That's what I've witnessed here.
What are the kind of the ways in which community participate? Not, obviously not just the family, but how does the community respond, especially if the family might be quite sparse, not so many people around.
Yeah. So, one thing that we do in IPM is that we tell people, it's a message that we pass on to the community, that this is an essential life skill. Caring for the someone with an serious health-related suffering is a life skill, because this can happen at any house, any time. So it's like any other life skill, like learning driving, swimming. And then this is a continuous skill building program for the community that's happening at IPM. We have already trained around 6,000 people now, and there is a huge waiting list. And once they learn the skill, we are giving them an opportunity to be a part of the care that is happening within their community. So what they become, in simple terms, what they become are they become the companions of the people who are already suffering. So, if a clinical team, either they're seeing the patient at home or in the clinic, they'll be maybe maximum they'll be spending a couple of hours with the patient and the family. Rest of the time, it's just the patient and the family in the house. And most of the time, they're alone. If you look at a family, a nuclear family, the wife will be going for work, husband might be on the bed, children might have gone to the school. So most of the time, this person is alone. So what the people do within that in an informal community network is that they visit them, they sit with them, they listen to their stories, they ask them about their thoughts and emotions. So it's just informed skills that they are using for conversation. And during that conversation, there will be a lot of things that they will hear about the spiritual crisis, about the social issues that they're having, about a lot of other things. So then the community comes together for some other things. They make a plan. Say, for example, the breadwinner of the family is on the bed and is not, and that family is suffering. So what we do is that the community members come together and make sure that there is enough resources that they mobilize from the community to make sure that there is enough food, the education of the children are not affected, and even in some cases, we have people who are on wheelchair due to paraplegia and other things. So they most of them would have been the earning members of the family. So the community comes together to teach some vocations like umbrella making and things like that, and making sure that their finished products are collected and sold. And in many of the houses, there are this, especially housewives who who cook food, or they make pickles, they pack it up, and then the community they sell it off, give the money to them so that their dignity is restored. So once the community uh, is coming together to take charge of this, if they have that ownership, they will somehow find ways to address most of the issues that the family and the patient are facing. As a pioneering institute in palliative care in Kerala, uh, there is a model that we tried out and failed. In the initial phases, what we have been doing is that whenever there is a palliative care need reported from different parts, we were trying to reach everyone. But as you as an institute with very few people, you have a lot of limitations. And then while we were working with some small pockets, some few people there, especially doctors and nurses, we call them the link centers. So you are the center or the clinic in charge, and then you have a lot of link centers. And then we realized that this is not the good way to go forward, because you will not be able to reach everywhere, and palliative care is a universal need. And if you look at the issues that you have to address, it's mostly social, emotional, and other things. What they need is companionship, and that anybody can do. And so we told people that, okay, what we'll do is that we'll teach you skills, and we'll let you know how to set up a unit. And if people from your neighborhood can take the lead, we'll give all the technical support, all the know-how, but you will have to run the show. And that when that message started spreading out, people realized that, oh, this is something like any other social initiative that you built to address some of the social issues of the society. And because of that, every village, they started discussing this. People started coming together. They realized that, oh, this is something that we should also have in our community. And the people who were coming together were retired school teachers, auto rickshaw drivers, tuk-tuk drivers, homemakers. All of them were coming together. And then those who have some time to spend, little more time to spend, and also those who have some leadership skills, they formed the top team. And then they registered this as a as a society, a charitable society according to the law, and then they run the show. And so what they were doing was that with the support that we were giving them, with the training that we were giving them, they were just visiting the patient. They were, trying to understand what's happening there, and they were trying to come together to solve some of the things with whatever knowledge and skills and connections that they had. So then they realized that there is a very important component that they will not be able to address, which is the medical issue of the patient, which is pain, wound care, these things. So for this, they needed a doctor and nurse. So then they started, looking at for doctors and nurses who are trained in this particular area. And there were a lot of them because, institutes like ours were running these programs. So there were doctors and nurses who wanted to work in this, in this area. So then these community members will put out a advertisement, and doctors and nurses will apply for that, and they do the interview. So if a doctor and nurse for come to a community clinic, tell them that they wanted to work there. The people who will be interviewing you will be one of these persons, like a retired hand or a school teacher or someone like that. And if they see that this guy is really passionate and can do the job, they appoint them. And even the salary, they're paid good money also. So even the salary for them, monthly salary for them, comes from whatever little money they raise for the program from within the community. It's all mostly micro donations, not like a big grant from a corporate, nothing like that, but little money, set aside by people, which runs the show, and it has been fantastically going forward.
So you start with community organizing. The community organizes about what it can do to look after people suffering from life-limiting illness, caring and loss. And then the community employs the doctors, not the health service. Is that right?
No. Yeah, not the health service, because these are all, see, especially in our context, the health service is already overburdened. Like there are a lot of things that they have to do, like right from immunization to, a lot of other things. And most of the time, what happens is that, say, for example, the Tertiary Cancer Center of Calicut Medical College is near to our institute. So every morning, from that institute, few patients and their family members are told that there is nothing more that can be done here. So we are discharging them. And when they are discharged, they are going to their home. And many of them, they get registered at our institute. But what we are looking into again here is to their, physical issues, their problems, their pain and other things. But one thing that we are sure, like when they go back to their house, we know that there will be regular support and care there that is organized by the local community. And for that also, you need a doctor and nurse and other people who can support with the physical ailments of the patient. And that doctor and nurse, they don't come from the already overburdened formal medical system, but to fill the gap, the community are mobilizing resources and they are appointing the doctors and nurses. So they are fully with them, not with the medical system.
So the doctors and nurses are answerable to the community, not to a health service board or anything like that.
No, if you're a government doctor working in health service, you are often you are answerable to the formal system. And I don't know whether there are occasions where people are really monitored and looked into whether they are doing their job in health system, because it's a very complex system, and as I said, it's overburdened, and there are a lot of political issues and things like that. So the monitoring and the quality management is not something that is very well taken care of, even though the government has put a lot of efforts there. But when it comes to community, it's a very small unit. It happens in a village. So there are very few people, and they make sure that there is an universal coverage. And then the system is so intact, and people are always vigilant. So the doctor and nurse, they have no other go but to do their job properly. Otherwise, the whole system will be looking at you. Not the formal system, but the community system will be overseeing your work, and not with a rigorous documented checklist or something like that. But you're working with them. You're in the community. If you go for a home care, that will be a classic example to say. So even the home care is the weekly charting of the home care is done by the community members and the clinical team together. So the clinical team will have to, talk about the patients according to the severity of the disease. They'll have to make the plan, and the community will have to be there to, discuss this and make sure that it's a collective plan. And when you go for the home care according to the schedule that you have made, you're not alone. So there will be the driver, there will be the doctor, there will be the nurse, and there will be at least two more people who are these volunteers from within that community. So you're all doing it together. And what I've seen is that most of these doctors and nurses are really, really good. They have that passion to work with the community, and it's not a rigid system like with a hierarchy or something like that. But it's a collective effort, and I've been on home care a lot, so there will be doctor, nurse, all of us will be there. I'm not a clinical person, but we tells doc, we talk about a lot of things. And once you are just going to enter the house of the patient, the next person that you have to see, we take a break, 5 minutes, look at the case sheet together. What are the things to be done for that person from the community side, from the clinical side? So, it's all discussed together, and then we go there. But in some cases, there will be instances where a doctor or a nurse is not working to the expectation of the community. Then the community will clearly say that we are sorry, doctor, we don't want your service anymore. We are going to look for someone else. So that's very direct. So yeah, that's how it happens.
And have you had that happen?
Yeah, a couple of times it has happened. For some of the nurses were fired. A couple of doctors, they thought that even one of the doctors whom I personally know, is very good and skilled, technically very skilled, but the community thought that he doesn't carry that compassion which you need along with that technical skill, and they thought that, oh, that's not good for our patients. So then they said that, sorry, doctor, you will not be able to engage you from next month on. So that's it. Like you can't help it. Like they are the owners, and it's their show.
Yeah, I mean, it really emphasizes the point that that the care that's given is care for the community. It's and it's embedded in community, and therefore the responsibility and the accountability is to community. So it's like deeply embedded in everything that you do is community.
Yeah.
Which makes sense.
Yeah, it's by the people for the people.
Yeah.
I mean, it's by the community for the community. Yeah. And I think that once you get a taste of it, once you go out into the community, you're gonna love it, because there are a lot of things that will personally benefit you as well as a doctor. You will have a lot of human connections. You will have lot of people with you, and whenever for our doctors, the community, they regard them as one of ours. Like, this is our guy. So whenever there is some support needed, because we are all human beings, sometimes we also will need a lot of connections for a lot of things, and it's already there. They are just a phone call away. So you are also personally benefited, and when you go out into the community, this will also result in a lot of system change. Like when we went out, the clinical team went out into the community, the kind of respect and dignity that they had, they all feel very good about themselves. They feel proud about themselves. And that particular incident of a home care vehicle with a doctor, nurse, and community moving around the locality, it builds a lot of public interest. So the next village also see, they say that, oh, we need something like this. So this is contagious. And then law and also when it is contagious, when lot of the community members come together, so they all need doctors and nurses. So you're creating opportunity for other doctors and nurses. And when this is spread in the community, the government will not be able to keep on. So in Kerala, what happened was, when we were doing this in the community, we said the government told us that, oh, you are doing a good job. We'll give you some money to better this. So IPM told the government that we don't want any money. But this is not just our problem. This is your problem as well. A patient with a palliative care need will come to any department of any government hospital. But what are you going to do about it? So then what should we do? We said that we'll help you build the system. You spend your money within your system. It's easy that we take the money and do our job. No, build a system in your. So if you look at Kerala now, in every village, all primary health centers has a basic palliative care unit. And who is leading it? A nurse. So that means you are building, opportunities for clinicians, both in the formal system and also in the community system. So personally, it's a huge benefit for you and for patients. These community members, since you have a very good rapport that you have built with them through your visits into the community, these people the community members will be the bridge between you and the patient and the family, resulting in better care, complaints, a lot of things. So I think this is a win-win situation, both for the community, for the system, and as well as for the clinician themselves.
And do you have any selection criteria for patients? Do you only see a particular, like mostly cancer, or is it for any kind of disease?
Uh, that's a tricky question for us. The thing is, we don't have a lot of systems to take care of patients with serious health related suffering. So when we started with cancer, for example, we knew that we also had the wrong notion that palliative care is for people with incurable cancer. So we started with them, and then since we were working in the community, somebody will come and see that person who is on the bed with old age is having bed sore, he's having a stroke, and he is also left out from the hospital. How can we ignore them? So then we started taking in people with old age issues, and then there were people who because of accident or fall from a height, they injure their spinal cord, and either they are quadriplegic or paraplegic. So then people, and not us, but they started asking themselves, like, what are we going to do with them? They also need support. They are having urinary tract infections. They are having bed sore. They are not able to work. Their family is suffering. Their social income has stopped. So what are we going to do about it? So then they extend to the care to them, and even to psychiatric schizophrenic patients and all. So later, the community, another organization came up with a program exclusively for psychiatric patients. So then we were able to refer all our psychiatric patients to them. So for us, it is very difficult to draw that boundary, saying that we'll look into only these patients. What we are looking at is suffering, and then we are trying to do our best for all of them. For paraplegic patients, maybe in a more developed country, there will be some other system who will be able to look after them. But in a setting like ours, when you see a suffering, you will have to make sure that they are also getting some support. Yeah. So, but yeah, the broader focus is on bedridden, incurable illness, the dying, things like that. But we are not limiting it.